Hello everyone, welcome to our today's video. I am Dr. Anuj, a general surgeon from Bangladesh. Today I will discuss on an emergency topic, and that is septic shock. Septic shock is very well countered in every aspect of medical science, whether it is gynae or in medicine, and very common in surgery. This discussion will be aimed at the interactive oral examination for FCPS in Bangladesh, as well as for short answer questions of same examination. But I think this discussion will help everyone, as this topic is very important, and I will try to discuss very common principles or common things regarding that issue. So let's begin our journey. First of all, I will discuss some questions, some problems or some scenarios. My first scenario, a 40 years female admitted into your unit with history of sudden severe pain in abdomen 1 week back. She underwent a surgery, and on 5th day following laparotomy, she experienced severe wound pain with cellulitis of wound with crepitus. She also had respiratory distress with partial saturation oxygen is 85%. And the second scenario is a 24-year-old man presents to the emergency department with acute onset pain and redness in his scrotum, penis, and perineum. Upon examination, you feel crepitance over the erythematous area described, which emits a foul-smelling grey discharge. So, scenarios may be like that, or it may include many other options also. So, but basic things are same. In today's discussion, I will try to discuss on the questions which are asked in IOE, especially the question regarding history, examination, investigation, and diagnostic. Okay. So first of all, in IOE, the scenario, after telling the scenario, your teacher will ask that tell 5 points in history you want to like to ask the patient, or 5 different examination regarding that issue, or 4 relevant investigations with justification, or may ask that tell me the diagnosis, or your teacher can ask some relevant basic. Also, in another stem, then he may ask some investigation related that treatment or management options, and also some rational use of drug or surgery, and even some adverse effect or prognosis or complications. So that questions, that is a typical question that will be asked in interactive oral examination, as well as that are very important questions which can come in your exam, written exam, as well as it may come in OSPE also. So first of all, if I look at the history or case scenario 1, that patient is a postoperative patient, and we are talking about 5th day. So particularly, we need to know about the details of pain. Okay, and that pain, that history 1 week back. So that history, whether the site of origin was where, okay, at onset was how, character, radiation, aggravating factor, relieving factor, or something, severity. So this Socrates, we may ask him. Plus, this postoperative follow-up, I will request you guys to go for RCS manual, or even the surgery final or surgical finals by Lumley. They mention properly or very adequately about the postoperative history taking and follow-up. So have tried to enumerate the points here according to that surgical findings by Lamley. So after detailing the history of pain, we should ask about any leg pain or any chest pain in that period. Chest pain and leg pain. Leg pain is for deep vein thrombosis and chest pain is for RTI or something. Okay, and we have to search the operation note, and the finding part. That what was the finding? Whether that patient had, whether the surgeon has found any perforation or it was an obstruction, and what is the level of the obstruction, or he may have found an ischemic or gangrenous bowel. So this operation note will guide us, and also the level of contamination also be noted by that by the operation note. So this operative findings is very important here. Then we need to know for the systemic features like fever with chills and rigor, cough or shortness of breath, even the urinary tract infection like dysuria, okay, and leg pain again. Then another systems like bowel movement, whether the bowel is moved or not. Ileus, as this is related to laparotomy, ileus is very important. So bowel movement, post-operative nausea, vomiting. Okay, even you can tell that yellow discoloration of the something. Okay, spike the temperature, আমরা আগে বলেছি. And then you need to know about the bladder activity, that whether he or she has passed her urine, amount of urine, how many times she has passed urine. Then drug history, what drugs she is taking, and any particular drug history like aspirin or clopidogrel, whether these things are we need to go for. So that is postoperative. If the scenario is of any kind of surgery, that history taking will be like that. Okay, so and that is taken from lung. I have treated. And regarding the second history, which is about an soul and perineum, soul and scrotum, something. And you guys have, I think, your diagnosis in your mind that is Fournier's gangrene, which we call necrotizing fasciitis, which occurs in scrotum or even in vulval region, that is called what? Fournier's gangrene. And if in first case, if it occurs in anterior abdominal wall, then we call it Milanese synergistic gangrene. So in case of second, the case history, other things as like as, okay, but we have to look for the history regarding epididymoarthritis, okay, or any perianal pain or something, because this Fournier's gangrene, the source may be scrotum, epididymoarthritis, or maybe perianal abscess or something. Okay, so we need to ask then about this, and we need to ask about some history of minor injuries or procedures, such as any bruise or scratch over the perineal region, or the urethral dilatation or anything. Sometimes in hemorrhage we inject sclerosant or something, or even periurethral open abscess will drain inadequately. That may lead to Fournier's gangrene. And the patient will present with sudden pain in scrotum with prostration, pallor, and pyrexia. That is the feature and written in Paley and Love. And you need to know about the immunocompromised status of the patient, like whether he is suffering from diabetes mellitus or he is alcoholic or smoker, and in case of drug history also, whether he is suffering from cancer also, drug history. So that immunocompromised history we need to take. Now we come to the next point, that examination. So if I go back, so if in your IOE, your teacher will ask about the 5 points in history. So you take the points, and from this you choose most important fact and tell it to your teacher. Now, examination. So examination is divided into general examination, local examination, and we also divided it. And in Longley or surgical finals book, first of all, when you all go to observe, we follow up a post-operative patient, we will not look at the vitals first. First of all, we need to look for the lines. Okay, lines, that means infusion line, transfusion line. Okay, and drips also. That the order is written here is 20 drops per minute, but the drips, the drops are going in 10 drops per minute or 60 or 40 drops per minute. So you have to mention here that what are the drips and something. Lines are okay or any clogged. Yeah, line may be clogged, line may be blocked, inked. So the lines should be checked, and the drain tubes in properly placed or not, proper inside, NG tubes. NG, if the tube is there, okay. NG is working or not, or clogged, and also very important, catheter. You have to look for catheter. Then mental state, like then you go ask the patient whether he is oriented in time, place, or person. Then you go for to look for vitals, blood pressure, pulse. Okay, and in that particular case, as we are talking about septic shock, you guys all know that in septic shock, the temperature, the periphery will be warm, not regarding hypovolemic shock, where there will be cool climate skin. But in that case, there will be warm periphery. The pulse will be high volume, not rapid 3D pulse, high volume pulse. Respiratory rate will be increased, temperature, I told, will be increased. Okay, so that is the thing. You have to auscultate the chest here, and you need to look for the calf muscle for tenderness, deep vein thrombosis. You need to take in mind always. And then you need to go for the charts, some charts in post-operative patients, like temperature chart maybe there, swinging as a temperature. Okay, intake output chart, very important. It will tell about the perfusion. You guys all know that urine output is the most important thing, or initial input will be given by the urine output, whether this patient is in shock is progressive or not. Then drug chart, follow-up chart, and if the patient is diabetic, so the diabetic chart. So these charts you need to look for. And if I tell about the local examination, okay, in case one, as this patient is having infected wound. So there are two grading systems. One is Southampton grading system, and another is SFC's grading system. In Southampton grading system, the wound is better categorized because that Southampton grading system grades the wound and operative wound into 5. 0 to 5. 0 that means normally healing. 1 that means healing but there is mild erythema or bruising. And that is also subdivided into 1A, B, C, you guys all know. And in case of 2, there are erythema plus other signs of inflammation. You guys all know the signs of inflammation, calor, dolor, robot tumor. And 2A, B, C, D, like at 1 point A, if it is found in 1 point only, A, around the suture line B, along the wound, that is C, and around the wound, that is D. Then if there is clear or hemocerous discharge, then it is 3. If there is pus, that will be grade 4. And in case of deep or severe wound infection, with or without tissue breakdown, that is grade 5. So wound grading is according to Southampton. And in case of SFC's grading, that is also discharge, additional treatment, serous discharge, erythema, poor net exudate, separation of deep tissues, isolation of bacteria from the wound, and inpatient stay prolonged over 14 days. So there is a point. So if you can grade in your question, in your long question, may particularly teacher may give the question according to Southampton grading. That was pass from 1 point only and less than 2 centimeter. So you guys all know that is 4A. Okay, teacher may will give a question that Southampton getting. So that will be 4A. Okay, so that grading is very important here, and you should grade these things. Then we'll tell about the surgical site infection. As this question is regarding this, you guys all know that this infection within 30 days of an operation, or if any kind of implant is given 1 year, some books written or new literature, so there's 2 year if any implant is given, and that will involve only the skin and subcutaneous tissue, and at least one of the following, like if from incision prudent discharge, if I send for culture, the organism will be identified, at least one of localized pain, localized swelling and erythema, and diagnosis of superficial surgical site infection by physician. So that is surgical site infection and superficial. Another one is deep. It is same as superficial, except that it involves deep soft tissues like fascial and muscle layers. And in case of organ space, it involves any part of the body deeper than fascial or muscle layers that is opened or manipulated during the operative procedure. So that are the things we need to go for. Now we'll look at the local case 2. And in that case, the scenario also stated everything, that there is small necrotic areas of skin, and that is entire scrotal and penile coverings has been sloughed out, leaving testes exposed but healthy, and there will be crepitation fouls mainly exuded. And for that necrotizing fasciitis or foreigners gaining, there are a few points you might need to know. There will be unusual pain. So history, you need to mention that there is unusual pain. I have mentioned previously. Edema beyond area of erythema. Important point. Crepitus, skin blistering, grayish discharge or dishwater pus. There may be pink or orange skin staining, or there may be focal skin gangrene, or shock, or features of coagulopathy, or multiple organ failure. So, that things you need to know. Now, the most important part, investigation. First of all, the complete or full blood count. And in full blood count, you will look for WBC count, neutrophil count. You may look at eosinophil count also, lymphocyte count, other counts. Also hemoglobin level, very importantly, and also ESR. ESR, the things. Then we need to know the glucose, glycemic status, random blood sugar, fasting of blood sugar, and importantly, in that particular case, serum electrolytes. So that patient, I think he is in nothing but os, so we need to go for serum electrolytes. And also serum creatinine, as that patient is having shock, so there will hypertension, and that will be treated by serum creatinine also. And then in case of patient is shock, we need to go for an arterial blood gas analysis. And we guys all know that there is metabolic acidosis in arterial blood gas analysis. And you may ask that why there is metabolic acidosis in shock. So shock that means that is the patient is underperfused, and in underperfusion there is lack of oxygen, which is stated as anaerobic condition. And you guys all know in anaerobic glycolysis, glucose is not produced, rather than glucose, lactate is produced. And then lactate is consumed as lactic acidosis. That's why there is metabolic acidosis in shock, and which is compensated by respiratory alkalosis. Okay, so that particular in case of the AVZ, even that scenario may come in OSPE examination, where that scenario, that pH level, okay, acidosis, that means pH will be less than 7.4. Metabolic, that means that will be bicarbonate level will be also less. Okay, metabolic component, that is everything is in similar states. Okay, I recall by mentioning one thing: if pH is low, and partial pressure carbon dioxide is more, then that component is respiratory, vice versa. Okay, but if pH is low, even the partial carbon dioxide is also low, then that may be metabolic component. Then look for metabolic component. That's why I try to recall. Another important one is base deficit, and base deficit also excess also called. And normal level is -3 to -3 millimole per liter written in RCS. In some books, like -2 to +2 milligram per liter. And that base excess or deficit component, it state about metabolic component. If it is low negative, that means it is less than -3, then it is acidosis. But if it is more than +3, then it is alkalosis. So if it is more than 6 millimole per liter, there will be higher morbidity and higher mortality. So base deficit is very important, and that is also one component of end point of dissertation. Short note may come, teacher may ask that what is the end point of dissertation. So that are the things. That is base deficit is one component. Clear? Later on, another component is mixed venous oxygen saturation. That is also very important. I would like to describe that things, and that is taken from the Bayesian lab. Okay. First of all, I just read the things. So the percentage saturation of oxygen returning to the heart from body is a measure of the oxygen delivery and extraction by the tissues. Actually, the actual value will be taken from the right atrium, but we cannot take this. We take this from supravenous cava. That's why it is called mixed. And in case of mixed saturation, that normal level is 50 to 70%. If it is less than 50%, then that patient is whether is in shock, which is whether it is due to hypovolemic or cardiogenic shock. But if it is more than 70%, it is called high mixed saturation. That patient is in having sepsis, septic shock. So septic shock patient must have this mixed venous saturation is more than 70%. And in sepsis, why it occurs? In sepsis, there is at cellular level there is disordered utilization of oxygen. Oxygen utilization is disordered. And as well as in microvascular level, there is arteriovenous shunting. For that reason, in cellular level, less oxygen is presented, as well as dead cells. Less oxygen plus those cells cannot utilize properly. So less oxygen plus less utility. So that is the most important point, and that is the basis. Look at this. We have stated that in septic shock, that level will more than 70%. But if that patient is having features of sepsis, but saturation is less than 70%, then you need to think about that that patient is having hypovolemic or cardiogenic shock along with their septic shock. So I think that thing is very important for you guys. After that, another one is important is serum lactate. That is also a component of end point of resuscitation. Usually less than 2 millimole per liter is normal. More the level, that means more lactate is accumulating, and that will simple thing. More lactate accumulating, there is more metabolic acidosis. So patient morbidity and mortality will be increased. So more than 5 millimole per liter, that level will be more increased. Now we can advise a chest X-ray. And you guys all know this Berlin criteria for ARDS, and one component is chest X-ray, which will show diffuse bilateral opacities. Look at this X-ray film. There is diffuse bilateral opacities. Very much important for that particular COVID area, because these findings is also found in COVID. And also we need to take an own swab of blood culture. If the wound we can take the swab from wound, then send for that. If we cannot, then we need to go for blood culture. Okay, and blood culture we need to take 2 times and 2 particular syringes blood culture. And also we need to investigate or we need advice on inflammatory mediators like CRP, C-reactive proteins, ESR, and also in shock, procalcitonin. That thing will discuss in the management component. Now, that later one is diagnosis. What is your diagnosis? So, first of all, before diagnosing that shock, we need to know that some terms like SIRS, systemic inflammatory response syndrome, and that thing, two of the following should present or must present. One is hyperthermia more than 30 degrees centigrade or hypothermia less than 36 degrees centigrade. Patient may have tachycardia or tachypnea. WBC count more than 12,000 or less than 4,000. If two of the everything found, then we can call it he is suffering from SARS. Okay. Now sepsis and septic shock. Previously, that was even in William Love, that definition is not there. That is taken from Davidson and that is from the Q SOFA guideline. And that guideline you should follow in case of defining sepsis and septic shock. Okay, sepsis, that means that patients with suspected infection, okay, who have two or more of the hypotension, and the definition of hypotension is systolic blood pressure less than 100 mm of mercury. In every shock we found it. Altered mental state, that means Glasgow Coma Scale is less than 14. And tachypnea, that means respiratory rate more than 22 breaths per minute. That things are very normal, I think. But in suspected infection, if you find two or more of that things, that patient is suffering from sepsis. You can define it. Okay? And septic shock, to define a septic shock, you clearly, there may be underlying circulatory or cellular metabolic abnormalities associated with substantially increased mortality. That defines as the sepsis. That means two of above the four, above the three. You should present there. Sepsis and both of but persistent hypertension requiring vasopressors to maintain mean arterial pressure more than 65 mm of mercury and serum lactate more than 2 millimole per liter. Clear? So that is the definition of sepsis and septic shock. So mind it, the questions are now very specific here. So even in your question, the things may be added and teacher may tell that, okay, this sepsis or septic shock. Okay, so you need to memorize these things. You need to practice this thing in practical life. That's why there's important things you can diagnose that thing particularly, specifically. Okay, so if I now tell the diagnosis of that things, first question, if I recall this, that was a 40 years woman. So in writing diagnosis, I prefer, or even in many international books state that in diagnosis you should tell the age of the patient, gender of the patient, like 40 years female with, okay, laparotomy diagnosis, that superficial or deep or organ space surgical site infection following laparotomy due to, I don't know, and shock, and classified as shock. Septic shock with something. Like she was, her saturation was 85%. So I think she is having some respiratory failure or something. So in diagnosing, mention everything. So your teacher cannot cartel any mark. So diagnosis is very important. It should be graded. It should mention every details, and it should tell all important things also. So for diagnosing that things, we need to go for this Southampton grading, SSS grading. If you can recall everything in your diagnosis, give input there, that will be more better for giving marks. Okay, now some relevant basics. Your teacher may ask that if you explain a patient is shocked as metabolic acidosis. So I think I have discussed it. Even he may ask that explain warm periphery in septic shock. You know, in other shock, periphery is cool and clammy. In septic shock, it is warm. Why? Because septic shocks is due to infection. Actually, that was by gram-negative septicemia, but nowadays gram-positive toxins also cause septic shock. And that gram-negative or gram-positive microorganisms, they release some mediators, inflammatory mediators like interleukin-1. That interleukin-1 is pyrogen, it causes fever. Deoxynitric factor, it causes fever as well as hypertension, and nitric oxide, that that is responsible for vasodilation. You guys all know the skin is the largest organ in the body. So if vasodilation occurs in skin, the periphery will be warm. So that's why there is warm periphery. And also histamine causes vasodilation, that also warms the body. So cause of warm periphery is nitric oxide. Inflammatory mediators, like your teacher may ask that who explain, or in case of short answer question, explain why, or explain blood pressure decreases in septic shock. Why? That means some mediators like histamine, nitric oxide, or interleukins, that will vasodilation, causes vasodilation. In vasodilation, they decrease SVR. That's why the resistance decreases, so blood pressure decreases. Also, that some few mediators damages the blood vessel, so there is increased permeability, and due to this increased permeability, the blood pressure also decreases. Okay, so that's why that is the important thing, that why blood pressure decreases in septic shock. Like your teacher may ask or in question that after few hours of recitation, you see that the patient's periphery is becoming cold. You guys all know the septic shock, two types. One is warm shock and one is cold shock. Early warm shock or hyperdynamic shock, late cold shock, and that is worst thing. Septic shock patient goes cool, that means that patient is dying. Okay, so that why that is occurs? That occurs, it's simply by above method. The vasodilation, blood pressure decreases. If the period of shock is long, so that sympathetic nervous system get activates. This tries to increase blood pressure, that increases SVR, and this cools the skin and also prolongs the capillary refill time. That's why the patient has cold periphery, and also that patient goes to undesirable phase of shock. So guys, I think that's my today's video about a septic shock, in where I have described about the pathogenesis, then clinical features, investigations, and also diagnosis and some relevant basics of septic shock. In my next video, I will discuss on the management protocol of septic shock, and that will definitely be guided according to main books, Alien Love or Saveston or something like, and also some guidelines. There is some survival sepsis guideline. I will prepare the lecture on that guideline. So in your exam, final exam, guidelines are very important. You have to read the guidelines so that you can be updated and your preparation will be more better. So thank you very much for watching. Thank you again.